So, I'm Gill Attwood, and I work for the Complex Needs Service and TVI, which is part of Oxford Health Foundation Trust. And this is Simon and Stuart, who are both stars, who are ex-service users of the Complex Needs Service. And Dean, I'm sure some of you will know Dean, who is in the process of setting up the pathway.
The EUPD pathway in Berkshire.
Now, we've only got half an hour. You know, thinking about personality disorder, we could talk about it for days. So this is literally a whistle-stop tour in terms of just helping you guys as GPs to start thinking about some of those more difficult interactions that you may have with some of your patients. So, first of all, what is personality disorder? It's a mental health diagnosis, and that may seem quite obvious, but there's a debate going on at the moment about, you know, does it fall into mental health, does it fall into social care, where does it sit? But as things stand, it is a mental health diagnosis. Now, with personality disorder, we all have traits that are unhelpful. You know, as part of our own personality makeups, none of us are perfect. I hope you all recognise that. So we're all on a continuum, but there's a group of people who fall into the upper end of that continuum who would be diagnosable with personality disorder. And one of the things, or three of the things in particular, is that those particular traits that they are expressing is that they're persistent, pervasive and problematic. So if there's a collection of personality traits that a patient is exhibiting to you and they fall into those categories, maybe start thinking that it's a possibility. Now, they may also be coming into the consultation with a history of trauma, an instability within themselves, and that may be an instability in their sense of who they are. And Stuart is going to give an example.
I mean, this is one that I certainly can relate to, and one that I think certainly did impact on how I interacted with GPs. Obviously, if you have a very unstable sense of who you are, this means from meeting to meeting to appointment to appointment. I would have very different kind of ideas of goals, different ideas of what I was capable of. I'd often kind of have a severe mismatch between how I felt about myself, my issues in my life, when I made the appointment and then when I actually attended the appointment. Often I would go to an appointment and then just kind of feel that the initial concerns that I had when I made this appointment felt almost foreign to me. This was something, this is another person who had these kind of problems, whereas when I'm sitting in a GP surgery talking to a GP, suddenly I'm going to feel, okay, no, I can do this, I'm powerful, I want to go and get a job, and I want to go and do all these amazing things. And it can be very transient. I mean, just it can change so quickly. I mean, just in a waiting room, just depending on how the interaction goes with the person who books in my appointment, so that could kind of force almost a shift in terms of how I saw how I was going to be that day. Yeah.
They may be unreliable. They may talk about having difficult relationships, or you may experience having a difficult relationship with them. Their emotions can be unstable, so they can move between being angry, happy, sad, distraught, and that can happen fairly rapidly as well. So even within a consultation, 10 minutes, then you can see a range of emotions coming through. They can also, which is kind of like almost the opposite to that, is have a limited expression of emotion, so they can appear very flat. They can be very withdrawn and fearful of abandonment. And you have an experience.
I do with that one, yes. My experience with that one was when I moved to meet my GP. She was an incredibly nice lady, a very, very good doctor. I really liked her. But I was absolutely adamant that I wanted to make sure this doctor continued to like me, because I didn't want to sort of prove to myself that I could turn anybody to dislike me, especially a doctor who was incredibly nice and incredibly professional. And so every time I went in, I'd have this sort of narrative running through my head of, it's got to be light, it's got to be nice, along with all the other issues that were going on. And so when she'd ask how I was, my answer would always end up being something like, fine, thanks, with a bit of an awkward smile on, largely because I wanted to come across as okay and pleasant and that, and it got in the way an awful lot of what I was actually trying to say. And my constant wanting her to like me did rather... It caused some communication issues at times, which we'll come to a bit later on. But certainly I wanted to make sure she liked me above all else, rather than my own health at that stage.
And also, a number of people who would meet criteria for personality disorder will come up to the surgery with unexplained physical health complaints as well. And that, I guess, kind of for you guys as GPs can sometimes really muddy the waters in terms of, you know, what you're looking at. Now, to diagnose a personality disorder, I mean, there's 10 personality disorders. It's quite a long and complicated process to do that. And of course, nobody would expect you as GPs to be formally diagnosing. But what might be a good indicator is something called SAPAS, the Standardised Assessment of Personality. It's something that's very quick, that you can do with patients, and you know, there's validity to it. So it's been kind of tried and tested, and that may just help to kind of give you an indication. Now, these slides will be going out to you, so you can either kind of just print this off or Google it. It's on Google. Right, I'm going to hand you over to Dean now, who's going to talk about service provision here in Berkshire.
Thank you. So yes, my name's Dean Rutland. I'm a consultant medical psychotherapist. That is a psychiatrist who specialises in psychotherapy. And in my case, I specialise in psychodynamic psychotherapy and the sort of related therapies like MBT. So has anybody referred a patient with PD or suspected PD into secondary mental health services in Berkshire? I'm sort of expecting most people. I won't ask what your experience of that is just yet, but I will go through what is supposed to happen at least. I need to just sort of give a slight caveat that we are in the middle of setting up an EUPD pathway. So a specific treatment pathway looking at people with primarily EUPD, although obviously you know, there is often a sort of mixed PD diagnosis or PD and other comorbidities. So, but primarily EUPD, and so this might change a little bit in the next few months. But for now, this is how things work. So I'll get out of the way. So the idea is that we're going to try and make it as easy for you as possible, in as much as we've got the common point of entry. So all of your referrals to secondary mental health care, and indeed I think probably IACT as well, go through the common point of entry. So you just need to use their referral form and send it in. What I wanted to tell you really is kind of what happens next, because from your perspective, presumably you send your letter off, and then you get some sort of reply back saying essentially yes or no and what the outcome is. But this is the sort of the process that happens. So when you send the form in, using as much sort of relevant information as possible, the team does an initial screening. So somebody will have a sort of eyeball the letter and then decide, do we think that this is somebody that might be heading towards talking therapies of one form or another, or do we think that this is somebody who's going to need something more like the community mental health team, the CMH team? And essentially, if we think that it's likely or possible that someone might be ending up heading towards psychological therapies, then usually, although not always, a psychologist or a psychotherapist will then carry out the assessment of that patient. Otherwise, it's more likely to be a CPN or another allied health professional that does the assessment. And so straight away, we're trying to get the most skilled person to do the assessment in order to make a judgment as to what treatment is going to be required. So the psychologist or psychotherapist, assuming that the person's going to be ending up going towards a talking therapy in the end, will get as much information as they possibly can from the patient during the assessment in order to come to an initial formulation to then decide what the most appropriate therapy is. But you can really help us out at the point that you refer to us. So I know that psychiatric referrals are a little bit different to physical health referrals in terms of the information that's required. And I think that when we're thinking about people who might have personality disorder, that's even more the case. Because yes, we absolutely want to know what medication they've been on, we absolutely want to know what their medical history is, but there are some other bits that you might tend to gloss over if you were referring somebody to a cardiologist. That would be really, really important for us. And this is particularly the social and the personal histories, because that is what is going to inform our decisions. It's going to help us with the diagnosis, and it's going to help us decide what the most appropriate treatment is. So I absolutely understand the time pressures that you guys are working under, and you don't have the hour assessment appointments that we often do have in order to get all of this information. But often you will have known this person for a very long time, and so might actually have a lot of this information, if not at your sort of fingertips, then not too far away. So
can I just interrupt you?
You can.
Diagnosis by exclusion?
No. So personality disorder is not a diagnosis by exclusion and hasn't been for at least 15 years.
So
yeah.
the patient that don't like to be labelled as personality disorder.
Well, in part, this is sort of not your problem, I guess. So you can have the conversation with them. You seem to have these difficulties. It's in this area. And we can refer you on to the specialist who can then help you out and sort of come to a fixed diagnosis. It's really hard, I think, for you in general practice to be able to distinguish between somebody who might have bipolar 2 and somebody who might have EUPD. It's really hard for me when I spend hours with the person trying to figure it out. So we're not really expecting you to try to do that, but if you give us certain bits of information, it does make our job easier. So the difference between somebody who has personality traits, as we all do, and somebody who has a personality disorder, might be essentially, is it getting in the way of your life to a significant extent? So knowing about which aspects of the patient's life is being affected is really useful. So is it only at work, or is it also at home? Is it in certain social situations and not others? This is really useful information. This is really helping us figure out the sort of ballpark severity, just to start off with. The other bit is about the patient's relationships, and this is probably the most important bit. So when we talk about personality disorder, I think we're often talking about emotionally unstable personality disorder, although there are lots of other personality disorders as well. And there are all sorts of reasons for that, but that tends to be the case. And the key bit of information I think that we need is about the quality and nature of people's interpersonal relationships. So that might be things like, do people still have friends from school? Has the relationship with their family broken down? Has there been quite a sort of tempestuous romantic relationship history? This is all really, really useful information for us. And it might be something that you've picked up almost coincidentally, just from sort of talking to your patients, not necessarily in terms of you trying to get to a diagnosis. You may have just found this information out, but it can be really, really useful for us. And then the last bit, so when we're trying to figure out, okay, what therapy might be appropriate for somebody, or indeed if therapy is going to be appropriate for somebody, knowing if they've had any before, how useful it's been, and what aspect of it has been useful in the past is incredibly useful. So we'll often get, again, because I know you guys have a lot of time pressure, we'll often get a sort of printout of the sort of key interactions that the patient has had, and it might say CBT therapy. And then, so I would want to know, okay, well, how many sessions, and was that in IAPT or was that in secondary care? And how useful did the person find that? And if they found it useful, what did they find useful about it? And if they didn't find it useful, Why not? And are they still able to put those things into practice now or not? And suddenly, if you sort of scrutinise that information a little bit more, it can be really useful in figuring out, well, do we signpost somebody back towards CBT? Are we thinking IAPT? Are we thinking secondary care? So if you can include that information, that is really useful. Any questions about that?
Can I just ask quickly, you know the CBT that you mentioned just now?
Yes.
Will you not have that information because it's the IAP or the talking therapist providing that
Sure,
CBT?
so you may or may not, I suppose, but you can if you're thinking about referring the patients, you
Yeah.
could always ask them.
Yeah, okay. That is, but you know, the amount of information that you're asking about the CBT, which aspects, which is not, you know, that can be
Sure.
quite difficult for a GP to do in the consultation and give that information to you. One thing we could probably do is the letter that comes back from the talking therapist.
That would be great too, as long as the information's there somewhere, that's useful.
Okay, so they would have, I mean, we don't.
Hopefully they would have.
Fine.
It's, yeah,
It's a difficult one, you said in,
it
I
is.
mean, some of this information it's not difficult to include in the letter,
Yeah,
but to go into the information about the therapy itself
sure.
can be very tricky for a GP to do.
Well, it may or may not. I suppose if you've got the person in front of you and you're talking to them about referring to secondary mental health care, it probably does only take a few moments to ask those questions. If they're kind of already in your mind as things that might be useful information. I accept we're not going to get all of this information every time. It's not realistic. But if you can, it's really useful.
Sure.
Yeah.
Just thinking for a motivated patient, they could probably provide this information written in some sort of written form. If you told them what the questions were, could it be something they could go away, write down and bring back?
Yeah, we're not that fussed what form the information comes in.
As a sort of
As long
partly
as it's there.
self-referral, this is why I want to be referred. Would that give you information?
Yes, potentially, yeah.
But the common point of entry, they want usually a diagnosis before they consider your referral. Is that the case too?
That's an interesting question. So I think sometimes they will diagnose and sometimes they won't. I think if somebody is relatively unknown to them and we're looking at a potential PD diagnosis, they probably won't diagnose because they probably will only see the patient once themselves. But they'll signpost them onto us and we might see them a couple of times before coming to a diagnosis. But it's still useful to have the information. Okay, so then just to let you know what the sort of treatment and management options are within Berkshire, and again this is probably going to change because of the EUPD pathway coming out, but at the moment we actually have quite a lot of psychotherapy that is well evidence-based for treating EUPD, and that includes in our integrated psychotherapy department we offer individual psychodynamic psychotherapy, we offer CAT, which has got a good evidence base for EUPD, and STEPS, which is a group-based intervention broadly based along CBT lines. Again, has got a decent evidence base for EUPD. We have a specialist PD psychotherapy service, which is called IMPACT. I can't remember what it stands for, I'm afraid. But they do MBT and DBT. So again, these are long-term, so usually 18-month, mixed group and individual psychotherapies. MBT is more psychodynamic-based, DBT is more CBT-based, but they both have a robust evidence base for treating EUPD. And then in the east of the trust only at the moment, we have something called Embrace and Assist, which is more along the lines of a therapeutic community. It's a sort of enabling environment ethos. It is quite small. Hopefully as part of the EUPD pathway that will be expanded. And then there is medication at the moment. So the NICE guidelines for EUPD say that medication should not be a sort of primary treatment for EUPD. They say that if you're going to use medication for EUPD, it should be targeted at specific symptoms and should be short-term and should be reviewed regularly. So generally speaking, you should not be prescribing that classic combination of SSRI and, say, quetiapine for somebody with EUPD. There's no evidence, there's no good evidence that it works, and there's a lot of evidence that all medications come with potentially problematic side effects. So I know that sometimes you think, well, what else can I do right now? They come, you know, I've got somebody in front of me who is in a lot of distress, and it's going to take a while to get through to even an assessment in secondary care, let alone, you know, therapy in secondary care. What I would say is, generally speaking, the best thing to do is to hold off, and is to sit with that anxiety and think, I want to do something, but the only thing that I can do at the moment isn't the right thing to do, so I'm going to not. And obviously, you can discuss that with us. You can always call up.
Can I talk? The last time I think I had someone on the waiting list for psychotherapy, I think they waited well over a year.
So it varies. It varies across the trust. So in Newbury, at the moment, they've got relatively long waiting lists for psychotherapy. In Reading, it's actually only a matter of weeks for some types of psychotherapy at the moment.
So what is it in Newbury?
I don't know because I don't work in Newbury, but I think it's more in the year sort of area. Yeah,
Which makes things challenging for us.
it does. But just because you can't do the right thing doesn't mean that doing the wrong thing becomes the right thing to do. If you see what I mean.
That's something I'll be mentioning a little bit later, or something like that.
Excellent. And we're hoping to address that with the new EUP pathway, because we recognise that this is a problem. And since the complex needs service stopped functioning in Berkshire, I think there's been a problem of containment. I think it was an incredibly containing service when it was running properly, and that has been gone now for a few years, realistically, and we don't have the ready containment that can be incredibly helpful for people with a personality disorder. So this SUN is a service user network, and the idea is that it runs a little bit like the Getting Ready groups from therapeutic communities, and it will be something that people can access very quickly and very regularly. So there should be groups 2 or 3 times a week that people can access with relatively few barriers to getting in. And so that, I think, will hopefully be part of the solution to that issue, is that people will have somewhere to go quite quickly to feel contained. It won't be therapy per se, but it should be therapeutic.
And is that likely to be something that you guys would put the patient in touch with, or would you expect us to do that whilst we're waiting?
So in the original model, it's a self-referral to SUN. I think probably as we're setting it up, we will keep control of that, and then hopefully when the service is a bit more established, we will sort of segue into a self-referral model. I think that's probably all the time I've got to talk at the moment, so I'll leave that there.
So just going back to the issue of medication, within Oxfordshire, we do run therapeutic communities, and going back probably about 3 years ago, must have been about 3 years ago. Yeah, it's got to be.
I've got to work this out.
In
mad.
In one of the therapeutic communities, we had a medication amnesty. So because we work with people to help them to come off their medications, we asked the members of that group to bring all their medication in so that we could get rid of it for them. And this was the result. So this is just from 7 patients who brought medication in. 1,000 milligrams of diazepam, 432 tablets of fluoxetine, 140 tablets of zopicone, 100 200 milligram tablets of lithium, 59 grams of quetiapine. And I think the bit that is probably most staggering, and certainly fits with that, the unexplained medical symptoms, is 406 opioid tablets. Imagine how much this is costing.
As well as that, a lady in the group said that she kept her stash of those largely in case she ever needed a way out. That was her plan B. And she said that bringing it in was effectively cutting off that choice for her. The stashing of, I think, diazepam in her case was that possible way out for her.
Okay, so that's just kind of a cautionary tale, but it filled a black bin bag full.
I'd like to make the point, if I could, that I remember a patient who was exactly this sort of situation, but that patient had a prescriptions are coming from secondary care actually.
Yeah.
And
This
so not
isn't all
just-
from GPs,
it's
no,
not
of
just
course
us
not. No,
prescribing.
no.
Don't worry, I'm haranguing my exalted colleagues about it as well.
No,
And of
I'm not
course,
blaming
there's-
GPs for this at all.
But
also-
these patients have been through the system quite a few
Yeah,
times. They've
yeah.
accumulated quite a lot of treatments from various specialists. We're instructed to prescribe this, prescribe that, and so
Yeah.
we do.
You're right, and of course there are comorbidities as well.
Yeah.
You know, people with EUPD can be depressed. You know, they're more likely to be depressed even. So I'm not saying that medication is never right, but I'm saying medication for the wrong reasons is never right.
Yeah, but I do remember this particular patient who was going to go into a therapy and was told he would have to come off all the medication, which scared the hell out of him.
Yeah,
Yeah.
yeah, no, absolutely, absolutely. Very quickly, because we're nearly out of time, so
Well, I just ask to ask ex-service users, so from your point of view, if you're waiting to be seen by specialists, what can we do as GPs to help you?
we're probably going to answer that one, hopefully.
I'm thinking possibly, it's hard to know. Yeah.
Okay, so I'm going to hand over to...
You go first, Jade, if you want. It's up to you.
Okay, well, we're finding this as traps that clinicians can fall into. I mean, in terms of personality disorder, I didn't really present as, I don't know, imagine stereotype of EUPD or borderline, whatever you call it. I would always present, I had sort of massive issues in my home life in terms of relationships, as we've spoken about, in terms of what I wanted to do in my life, in terms of suicidal ideation. It was very difficult for me to actually go into a GP surgery and actually articulate this in a way that was in any way meaningful. I was very good at essentially describing my issues in ways that had no direct emotional connotations to them, which tends to have a sort of flattening effect to people. It's very hard to sort of connect to somebody that is telling you something with no real pull to it, to actually take it seriously. And in terms of medication, I was prescribed SSRIs. I wasn't sort of massively overdosed, but these were drugs that I had, was very aware had no real effect that improved my life. They were kind of useless to me. But I took them every single day, and I liked it because it represented this is something that somebody's given me to make me feel better. And that made me feel good because it meant that I had some sort of care, it meant that somebody mattered. I mattered to somebody. Fully conscious that this is it's just a complete waste of my time, it's not actually doing anything. And I feel like if somebody had asked me sort of on the level, do you think this is helping? I would have just said, well, no, not really. But as it was, I just kept going because this is all I had, so that was it. That was this is my care. And it was very easy for me just to keep going. And it was very difficult for me to eventually give it up when I just sort of looking to join the therapeutic community. But yeah, it's if you're not able to really reach out and ask for help, we talk a lot about relationships, actually being able to communicate with somebody, I would just go into the room and just minimize all my issues, just say, okay, feel very suddenly afraid that I was talking to somebody, and then just essentially try to negotiate the situation to try to end the appointment as soon as possible in a way that was sort of pleasing to both of us. So I'd be very good at sort of agreeing to do all these different things and saying, okay, that's a great idea, I hadn't thought of that. Go away, do nothing at all, or just stay completely hidden away from everybody, and then come back the next day and come up with these huge rationalizations how it's going to be different this time. And this is something that was quite pleasing, I think, to the GP in the short term, because it's like sort of getting reassuring strokes. But in the long term, just eventually people catch on, and then you realise there's this dead weight of the patient, and it poisons the relationship. And we never really got to a place where we were able to actually say, well, what is happening? This isn't working. But 10-minute appointments, it was easy just to keep going, and then just, for a very long time, just achieve nothing, but sort of feel quite productive once doing it.
Yes, I mean, my story is different and similar in many ways. It goes back to some things that Dean's certainly been saying, because when I first went in, I was very much, it was a case of clinical depression on the surface, and it definitely was, because as soon as I was put on fluoxetine, I was much better. I was out of that black stage, I wasn't walking in like this anymore, I was more upright. And that was all very well and good, and I'd go in for reviews, and like I said, my doctor, a lovely lady, absolutely brilliant, couldn't fault her. But the problem was, again, like I said, because I was sort of communicating in the way of, please like me, I wasn't really sort of going into the details, and so I was having more and more sort of problems still going on in my head on the side of it. And it got to the point that I started to feel quite sort of frustrated And then I'd sort of come across as quite ratty because I wasn't able to get to my problems, and even if I was, I couldn't express them, which I imagine was a little bit of a confusion for her, because she'd be sort of thinking, well, what are you trying to say? Quite often we'd find ourselves missing each other in communications that way. And I think eventually it got to the point that I just said, these pills, I don't want these pills, they're not working, nothing's working, it's all awful, just sort of a bit of a catastrophic meltdown. And her answer was, well, do you want to try a higher dose of fluoxetine, or would you like to try different antidepressants? And I just said a different one, because I thought, well, let's address it, and I was put onto sertraline. Which at the time I thought, yeah, that might be the right thing. All it was is I had exactly the same feelings. I was just really, really tired on top of them, so I ended up more frustrated, more ratty, and all of that stuff. And I stayed on that for a little while until eventually having the breakdown, and then I was in her office sort of saying, help me, please help me. And I mean, it's a time I can't remember that well, so I've no idea how I was actually coming across to the poor lady, but eventually she sort of started putting me through for therapies and things, but for that year and a bit on the sertraline, I think that was where a lot of the sort of difficulties were brewing up more and getting me more to the point that I was just, again, just coming into the office, ranting a load of nonsensical stuff and leaving again. And I think that certainly, because I've been sort of thinking about why, outside we're having a discussion about why was the sertraline put forwards, because I always thought maybe it was that she wasn't aware that there was a broader issue, maybe. But actually, again, this goes back to another conversation that was being had earlier, that maybe it was easier for her, because I imagine when I came in, her blood was sort of turning to ice at this point, heart was racing and all of that stuff, and I think it probably for her it was easier to put me on a medication and see if it works at that point, and go through with it. And I think, sort of to answer the question you asked about what to do in the meantime, I think that subsequently after she retired, I saw another doctor who was sort of seeing me through things and checking up on how I was, and what he did was a kind of containment, just to sort of sum up what I was trying to say and his understanding of it, to make sure we'd understood it. And then sort of say, this is what I think, but what do you think? And then sort of eventually making a decision around it. And I think with the previous doctor, I think her way of, I'm just trying to think how to phrase what I'm trying to say. I don't want to say getting me out of the office, because it wasn't like that. It wasn't her sort of trying to get rid of me. She genuinely was trying to help. But I think a lot of it may well have just been based on, let's just solve it now, rather than let's look at it in the longer term. And I mean, it is difficult if you've got somebody either screaming at you or sobbing and you can't work out what they're trying to say, but I think in the long term, to aim for the sort of longer cure would have been a better thing for everybody, and it certainly would have saved me coming back and getting more and more frustrated at her in the long run. And yeah, I think that's everything I have to say on the subject.
So I'm just very aware of time. So this kind of goes hopefully a little way to answering some of your queries in how can you as GPs actually start to manage some of the trapped and guard against them. And I think, you know, open communication with colleagues, so kind of amongst yourselves, but also, I hope I'm okay in saying this, Dean, that if you're unsure, phone and talk it through.
No, please do.
Is that advice to us?
Having regular, I mean, we call it supervision, but you know, a regular space for you to sit together, to think together about some of those more tricky patients that you're seeing. Maintain boundaries. So if it's a 10-minute appointment, you stick to the 10-minute appointment. If you know they're kind of pushing for you to extend it, offer them another appointment, but stick to your 10 minutes or however long it is. Or one of the stars in the past has spoken also about with their GP, they always had double appointments. So if it's somebody that you know is particularly chaotic, who comes in crisis constantly, maybe having negotiated beforehand that they always get a double appointment. Pay attention in particular to your reactions to people, because quite often, I mean, it's kind of in the psychotherapy world, it's called transference and counter-transferences. But what that's about is, you know, how their reactions kind of can drag you into that, and vice versa as well. So, you know, as Simon was saying, not wanting to upset his GP. And, you know, and I guess that could have been based on a relationship from the past or a fear of something from the past.
Sorry, just on that point, you guys as GPs used to be really good at checking in about this stuff, in that you set up Barlink groups. You know, Barlink groups started in general practice for this very reason, is that you're seeing really, really complex patients in really, really short amounts of time, and you can go away left with loads of stuff from all of these interactions. And I think making time to think about them and scrutinise them not only helps you not burn out, but it also helps you diagnostically. You know, there's really important information that gets left inside you, and that I suspect you don't think about enough.
In a different scenario, we could be sitting here in this room with these two guys standing who said that we were diagnosed wrongly personality disorder. The doctor discussed with us, we did the PHQ, GAD, and we honestly filled the answers correctly, and the calculations indicated anxiety or depression or a mixed disorder. The doctor gave us, you know, the alternative of the treatment. You want to take medication, you want to go to have a psychotherapy or talking therapy. All these issues were given to us, and it could have been a different situation altogether. So my question first to both of you is, how honest were you in answering those questions had you had filled those two questions before the medication was started?
In my case, probably unintentionally, not very. Largely again because, like I said, I was in very much people-pleasing mode, if you see what I mean. So, I mean, there is that sort of difficulty that you would then face. It turns into a par again with what on earth is this patient saying to me. And I think that it was, this was the one area I would say that my GP, I don't think she did quite as well as the new GP, which was the fact I don't think she looks behind what wasn't being said. I know that sounds like really horrible. I'm playing a game with you, you have to solve it. It's not intentional. But I mean, there's an awful lot of stuff that doesn't get said that shouts volumes. I mean, certainly, it's easier for me now. I mean, I can't think of examples because I'm past that a lot now. But I think certainly, if you could sort of see me sitting there going, yes, I'm fine. Yeah, no, it's great. I'm going now, and you can see it's not. It might be a sort of curiosity behind that side of things that would lead to more towards, to say the correct diagnosis, a more helpful kind of path. See what I'm saying.
But PHQ-9 and GAD-7 are screening tools for depression and anxiety. They're not, their sensitivity isn't bad, their specificity is pretty rubbish.
Sure, but this is a must tool for in the modern medicine when we are prescribing SSRIs or SARIs, whatever, that look at those tools, patients complete those tools, then we give the alternatives. You want, you know, some patients say, all I want is quick fix medication. I haven't got time to go on a talking therapy and things like that.
Well,
so,
that's their choice.
Yeah.
And, you know, and it is important to remember that probably 80% of patients that you see who meet criteria for a diagnosis of personality disorder will also have a comorbid disorder alongside it.
Yeah. It will be nice if you or someone else could devise a similar tool for us as GPs, similar to sort of PHQ or GAD, to give us at least some idea that it could be a personality disorder.
So that's what the SAPAS
There is that, and I
does
think
do that.
there tends to be just a sense in the interactions that something else is going on here.
Honestly, did you do the GAD and PHQ, both of you, when you started on medication?
I did. No, I didn't. It was a different thing for me. I mean, at the end of the day, I think the one thing I'd say, I can see a hand at the back there, where I think the one thing I'd say is it's our responsibility, but you're very much...
We are way over time, but I know that you've been desperate to
I
ask.
think that's about consultation skills, actually. It's, you know, about looking at the long-term and bigger agendas that, you know, we do every consultation, actually, and I think it is our role to explore them, or try and find them, and explore them. And actually, GPs, I would suggest that, you know, have been at the forefront of consultations.
Absolutely. But if you do want any further training, TVI do offer various trainings, and you can contact Sue or myself. As I say, it's going to be sent round. So if there's any training that you want or to think about, then contact Sue. Thank you.
Thank you.
So thank you very much for the heroic effort of doing a PV presentation in 30 minutes.
Well, I think it is a bit long.
Yeah. So our next speaker is Julie.